The project is called RADAR, which stands for Reorganizing the Approach to Diabetes Care through the Application of Registries. We're interested in looking at trying to better control diabetes in Aboriginal populations. Aboriginals are very high risk for diabetes, and we also know that in many of these communities there's just a lack of capacity from frontline personnel in terms of nursing, physicians, pharmacists, etc., to really tackle a complex problem like the management of diabetes. And so we wanted to see if we could look at a new model of care for these communities that could be potentially scaled up to not only serve these communities but other communities that are facing similar issues in terms of trying to manage their diabetes populations. Basically, the new model is it's kind of a two-part. One is from the community's perspective, does it work for them in terms of the nurses, the physicians, the patients themselves? Do they find the models a benefit to them to try to improve the care and efficiency of care within their communities? And then on the other side of the coin is a more patient-specific outcomes. Can we improve some of the major clinical markers that we know will improve outcomes for patients, such as their blood pressure, their cholesterol levels, their kidney function, etc. On top of that all, we want to make sure that we can do it in a cost-effective way. So most research programs in this area have really developed around the idea of if we put in registries, such as diabetes registries, heart failure registries, those types of things to try to track populations of patients, will that improve care? What we know is that registries by themselves generally don't work. People will populate them, but there's no one there to look after the data, look after the patients, and it becomes very overwhelming for them. On the other side of the coin, we do know that models of care that involve either case managers or care coordinators, as you want to call it, can also substantially improve outcomes. If somebody's there to help frontline people saying you need to look after a certain subset of the population, we know that works. So we wanted to try to see if we could put the two together. So that if we built a registry that has an integrated electronic medical record system, so it basically has all the patient information that you'd normally want for patient care, but then on the back side of it is a very important piece in that it would allow real-time data to be driven from those communities. So they could immediately see how many patients have had their blood pressure checked in the last 6 months. So that's what the first part was. The second part is we needed to address the issue of capacity. We know these communities do not have enough capacity to manage all the chronic diseases that their populations are facing. So we thought if we could get a care coordinator to come in who is not located in the communities. So a unique aspect of this is that the care coordinator would be located more centrally in Edmonton, in Calgary, something along those lines, but provide kind of remote care to these frontline individuals to see if that model could help to improve the outcomes of patients. At the end of the day, the benefits are really going to be at two levels. One, at the patient level, can we actually improve their outcomes by trying to prevent some of their complications of disease, improve their quality of life, their satisfaction with the healthcare system, etc. On the other side of the coin is, can we provide care that's going to get those outcomes in a more efficient manner? And so again, can we help support the frontline communities, their nursing staff, their physicians, etc., to get those outcomes at a reasonable cost to the system?